Morning, everybody. We're going to get started so that we don't lose time for the presentations. My name is Carmel Geoghegan and I'm from Ireland. So I'm delighted to be chairing this really important session this morning. And we have 4 superb pieces of research to be presented on the residential care. The first one we're going to is insights into the impact of relocations within nursing homes on residents with dementia, an interview study with stakeholders. And this is from Miranda Schreuder. I'm sure it's not right. And Miranda can give us just a little bit about yourself when you get to the podium. Thank you.
Thank you for introducing me. I'm Miranda Schreuder from the Netherlands. I'm doing a PhD research in the UMCG in Groningen. I hope I have slides. As introduced, I'm going to tell you about the insights into the impact of relocations within nursing homes on residents with dementia. I'm doing research into relocations from within nursing homes, so not from home to the nursing home, but within nursing homes. For example, to another department or another location or another care organization. You can divide relocations within nursing homes into group relocations and individual relocations. Reasons for group relocations can be outdated real estate, for which a nursing home can choose to build another nursing home, a new one, or to renovate the old one. Reasons for individual relocations can be change in healthcare demand or by choice of the family to move the resident to a nursing home closer to them. Although relocations within nursing homes happen regularly, there's not a lot of knowledge about the impact on the residents. So in the first part of our study, we have studied the impact of relocations within nursing homes on residents in general. We have done this via an interview study, and we found out that the impact varies per resident, per relocation, and per moment in time. And moment in time can be the period before the relocation day itself, or the period after the relocation. We also found some aspects that influence the impact. For example, the organization and communication of the relocation and characteristics of the resident, him or herself. And we found also some factors that facilitate a more positive impact, for example, good preparation and tailoring the relocation to the resident. Currently, I'm writing an article about this part of our study, but if you want to know more, you can contact me by mail. During this study, we heard from a lot of participants that the impact can be different for residents with dementia than for residents without dementia. So that caught our interest, of course. So we decided to do a secondary analysis on the same data with the question, what is the impact of relocations within nursing homes on residents with dementia? This is also the topic I'm going to tell you more about. We have held 17 mostly online interviews with various stakeholders. Part of the interviews were mainly about group relocations. The other part were mainly about individual relocations. And you can see for yourself that we have interviewed a very diverse group of stakeholders. Our goal was not to reach saturation on stakeholder level, but to get a broad overview about the current status of the impact of relocations within nursing homes, because there's so little knowledge about that. We used a semi-structured interview guide with the topics frequency, reasons and types of relocations, relocation process, the impact of the relocation and the evaluation of the relocation. We have audio recorded the interviews and we have transcribed them verbatim. We have analyzed them responsive and thematic, and the responsive analysis was by member checking the interview summaries and by doing a focus group with part of the participants to check our initial analysis and to deepen the analysis. Well, the results. We found that it was difficult for stakeholders to assess the impact for residents with dementia because some of the residents expressed very little response to the relocation and other residents did not seem to understand the relocation. They thought, for example, that they were on holiday and it was just temporarily, or they had a hard time getting used to the new routines in a nursing home after the relocation. Some stakeholders also observed enlarged anxiety and problem behavior in the group of residents with dementia. They thought it was possible due to the reduced capacities to cope with changes for this group of residents. In some of the residents, the stakeholders saw a decline after the relocation. In those cases, they found it hard to determine what the cause of the decline was. Was it caused by the relocation itself, or was it caused by a natural progress of dementia? So that puzzled the stakeholders. With the analysis of this study, we found out what the impact, what the stakeholders assessed the impact for the residents with dementia. But we were also curious, how do residents with dementia experience relocations themselves? So our research journey continued. My research is part of a research consortium named Relocare, and you can see in the there under which organizations are part of that consortium. And a colleague of mine of the consortium has interviewed residents with severe dementia themselves about a recent group relocation. And I'm currently analyzing these interviews, but I'm happy to share with you our preliminary results. We found out that some participants were very positive about the new apartment or the new environment. They felt at home, they liked their apartment, the personal stuff in their apartments, or the environment they recognized from when they were growing up. But other participants were not feeling at home in a new nursing home, for example, because they experienced their apartment as too big or with too little of their own personal belongings. For some of the participants, wayfinding was very difficult in a new nursing home because they weren't used to the new nursing home. Other participants did not have difficulty with wayfinding. And there was also a resident who did not really care about being relocated. He said, well, for me it doesn't matter if I still had lived in the former nursing home or I live in the nursing home where I live now. But I have to tell you, there were some challenges analyzing these interviews. Because of the severe dementia, some participants had no memories of the relocation day or of the nursing home they lived before. Some participants only gave short, two-worded answers, and other participants gave the same answer to every question. So it was hard to analyze, but we still feel that we found some important experiences from this group themselves. Well, to conclude what the impact of relocations within nursing homes on residents with dementia is, it's difficult for stakeholders to assess the impact on residents with dementia, but they did observe an enlarged anxiety and problem behavior in this group. And when there is, if there is a decline after the relocation, it's hard to determine the cause of this decline. And we found that it was challenging to study the impact on residents with dementia themselves via interviews. But feeling at home and wayfinding are important topics. Do you have questions?
We might hold the questions till the end because we can see how much time we've left, and we've also got people joining us virtually. I forgot to welcome them. From that we take, I certainly took, every person has a different experience, and whether they're, and where they are at in their... Is it on? in their journey. Sorry. We're going to keep the questions till the end because Rachel won't be here, so we have a little bit of extra time. And I'm just saying that it's obvious that every person has a different experience, and it's very hard to have, one fits all. So our next speaker is Helena Kullenberg, and she is doing her study on behavioural and psychological symptoms in patients with cognitive disease and diabetes, a register-based study. Thank you.
Yes, my name is Helena Kullenberg. I'm a nurse and a PhD student at Sophiahemmet University in Stockholm, Sweden. And I'm very thankful to Alzheimer Europe for giving me this opportunity to be here today and talk to you about behavioral and psychological symptoms in patients with cognitive disease and diabetes. And diabetes type 2 especially is a well-known risk factor for cognitive impairment and the development of cognitive disease. And the link to vascular dementia is relatively undebated, as it's clearly demonstrated that diabetes has an impact on cerebrovascular health. But later years, also the evidence for diabetes being connected to neurodegenerative disease, such as Alzheimer's disease, has grown larger. And Alzheimer's disease and diabetes type 2 share risk factors, but also pathological features, such as insulin resistance and neuroinflammation. And besides cognitive symptoms, most patients with cognitive disease also experience some form of behavioral or psychological symptoms in dementia, sometimes called BPSD. And it can be presented as a wide range of non-cognitive or neuropsychiatric symptoms. You can see in that blue picture all the different domains. And BPSD causes distress and harm both for the patient and for their informal and their formal carers, and it reduces overall quality of life. And BPSD is not always connected to the progress of disease, but it has been linked to brain atrophy and imbalance in neurotransmitters and neuroinflammation. And also it can be triggered by several factors such as bad communication, pain, or other diseases such as diabetes. So if diabetes has an impact on the risk of getting a cognitive disease, can it also impact the symptoms of disease? And there have been clinical studies showing that deterioration of blood glucose control can impact cognitive function and induce delirium, but the impact on non-cognitive symptoms is a bit more unclear. So we wanted to investigate this, if there was a difference in BPSD symptoms between patients with diabetes and patients without diabetes. And we had the possibility to do so in a large register-based sample. So for this study, we used data from the Swedish BPSD register, and that is a national quality register, mainly focusing on a structure method for improving care for patients with cognitive disease. And the register have over 100,000 registered patients with different form of cognitive disease, living in nursing homes or receiving home care. And most of the municipalities in Sweden have joined the register, or care units from most of the municipalities have joined the register, making it a unique possibility to study BPSD in a large sample with a large geographic spread. And the data input into the register is done by a multi-professional team, most often a nurse and nursing assistants working close to the patient. And they will cooperate with occupational therapists, physiotherapists, physicians, or next of kin as it is needed. They collect medical data such as drug prescription and cognitive diagnosis from the medical records. and they assess several clinical parameters, such as physical parameters, blood pressure, body temperature, blood glucose, and psychosocial parameters, as if the person have meaningful activities and meaningful interaction with other people. After this comprehensive evaluation, they put together a plan for the care, which is put into the register and updated as often as it's needed. But the challenge for us was that the register does not contain information on a diabetes diagnosis, and blood glucose has been measured but registered as a categorical variable, meaning a healthcare staff person have assessed if the person has a normal, a low, high, or fluctuating blood glucose. And these categories does not represent specific values, and it can be different between patients and different depending on who has assessed it. So for this study, we decided to use anti-diabetic drug treatment or prescription of anti-diabetic drug treatment as the classification of diabetes. So the final sample, we had 87,058 individuals that had this BPSD assessment and the information on prescription of drugs less than 4 weeks apart, so we could think that they were connected. Out of this, we classified about 10% as having diabetes, which is a bit less than you would have expected. And the group with diabetes was a bit younger. They had a higher proportion of men and a higher proportion of vascular and mixed dementia. So were there any differences? Well, as you can see in this graph, there is not that much difference. All of these differences are statistically significant, but it depends on the really big sample. The biggest difference was aberrant motor behavior and anxiety. But it's still just a few percent difference, and maybe that is not clinically relevant. However, when we selected a sample of patients with diabetes that could be matched to a patient without diabetes regarding age, gender, type of cognitive disease, the drugs we had information on other than antidiabetics, and the registered blood glucose, you can see that the difference is a bit more pronounced. And most of all, the patients with diabetes, it's the dark blue bars, they seem to have less symptoms in all symptom domains. So why is that? Why do patients with diabetes seem to have less BPSD symptoms than patients without diabetes? And we have discussed this, and of course there can be several explanations that we don't have data on in this data set. One thought is that patients with diabetes might get more time and attention than patients without diabetes. The diabetes-related self-care interventions, such as measuring blood glucose, examining feet, for example, and maybe some more attention around mealtime situations and drug administrations. And it has been demonstrated that time with staff has a positive effect on symptoms like anxiety and physical restlessness, for instance. But also, as we did not have information on diabetes diagnosis and used antidiabetic drug treatment as the group indicator, we could interpret this as a result of antidiabetic drug treatment, which is also interesting as antidiabetic drugs has been suggested as a treatment for cognitive disease. For example, metformin has been suggested to improve cognition or cognitive symptoms. So maybe antidiabetic drug treatment could be beneficial also for patients with BPSD. However, we also did a subgroup analysis of the patients with diabetes with regards to the registered blood glucose. And this forest plot shows the odds ratio for having symptoms in the different domains if you have a non-normal blood glucose compared to a normal blood glucose. And as you can see, most symptoms increase, or the probability of symptom increase, if you have a high, low, or a fluctuating blood glucose compared to a normal blood glucose. And the highest probability was for agitation and irritability, depression, and eating problems with eating and appetite. And this is not surprising, as we have seen in earlier studies that, for instance, a deterioration of blood glucose control can induce delirium, but also agitation. And poorly controlled diabetes has been connected to depression and affective symptoms such as anxiety. And that seems to be true even for people with cognitive disease. So in conclusion, diabetes, or perhaps anti-diabetic treatment, was in the study associated with less BPSD symptoms. And it also shows the importance of continued diabetes care and regular follow-ups for patients with cognitive disease, even if they're living in a nursing home or in a care facility, since a badly controlled diabetes seems to give more symptoms. This result highlights the needs for knowledge and the need for knowledge about diabetes and its self-care in persons working with these patients. Thank you so much for your attention.
Thank you, Helena. And I think it's great that the registrar is a fantastic resource for research, and I absolutely am delighted to see that psychosocial interventions is measured and recorded, because I think it's so important. Next presentation is from Mckenzie Dow from St. Joseph's in Shankill in Ireland, and the title is They're Allowed to Be Who They Are, Exploring Perspectives on the Social Model of Care in Long-Term Homelike Facility for People Living with Dementia in Ireland. Thank you, Mckenzie.
I hope I have slides as well. Hi, thank you everyone for being here. Like Carmel said, my name's Mckenzie and I worked as a research assistant at St. Joseph's Shankill, which is in Dublin, Ireland, and it's Ireland's largest nursing home dedicated solely to dementia care. So I'm here to talk to you today about a study we did where we interviewed staff and family members to get their perspectives on the social model of care that we implement at St. Joseph's. So to start, like a lot of places, dementia is on the rise in Ireland. Each year there's approximately 11,000 new cases, and the increase is happening quite quickly as the population ages. And as we know, if any of you have experiences with your own family members with dementia, a lot of times the goal is to stay at home and get care there. But for some people with dementia and families, the best alternative is living in a long-term residential facility like St. Joseph's. And in Ireland, approximately 20,000 people are living with dementia in long-term care. So, like everyone else, people with dementia deserve to be treated with dignity and respect, even when they're in long-term care. And of course, they have a right to maintain maximum independence, their abilities, whether they're physical, mental, social, vocational, as well as feel like they're included and have opportunities to participate in all aspects of life. And this is something that St. Joseph's truly embodies in their work. We also know that long-term care facilities that are more home-like, that are person-centered, that are designed with people who have dementia in mind are better received by care staff as well as family members of the loved ones in care. And we also know doing things like life story work can be really helpful for building on person-centered care for people living with dementia. So that brings me to St. Joseph's Shankill. I have to be honest, it's like one of the coolest places I've ever worked. The atmosphere is so vibrant, it's so warm and kind, and people are so engaged. And it has a lot of accolades that kind of speak to that. Not only are they excellent in their dementia care and their charity impact, but it's also the only nursing home in Ireland to receive the Investing in Volunteers Award, which is brilliant. The volunteers are integral to the St. Joseph's community. But also what makes St. Joseph's really special is it's what's called a butterfly home, and that's what we're researching today. So a while back, one of the nursing directors, her name's Norma. I don't know if she's watching, but hi Norma, if you are. She kind of sat back and said, okay, you know what, I don't think we're really doing this the right way, and I think our residents deserve better. So she, with the help of an organization called Meaningful Care Matters, introduced this model called the butterfly model to St. Joseph's. And this was a lot of work. The whole place kind of had to be rebuilt, restructured. A lot of construction was going on for a while to make it feel more home-like, and staff were trained in what's called the butterfly model of care. So in St. Joseph's, we have 6 different houses. We call them lodges, and each one is as vibrant as the next, and each one is designed and dedicated for a different stage of dementia. And the place is all about the butterfly model. So what this means is there's no strict routines, so residents aren't forced to wake up at certain times, they're not forced to eat at a certain time. It's really about their needs and what's best for them. The clinical stuff has all been stripped back, so there's no nurses stations, you won't see them around anywhere. Also staff, we don't wear name tags, we don't have uniforms, so you really can't tell sometimes who's a family member, who's a resident, who's staff, and it really just contributes to a sense of one community. And there's also no strict rules, so if a resident wants a pint of Guinness before they go to bed, they'll get one. And this really means that the place feels very home-like. Each of the lodges is absolutely beautifully decorated, and you feel like you're kind of going into your granny's house. Everything is very feelings focused, so we focus a lot on empathy and feelings first communication with residents. We use life story work as well, so when a resident comes in, they have this big box or a book that's all about who they are and who they were. And again, meaningful activities, so it's not a one size fits all. If someone wants to paint, they're going to paint, but not everyone wants to do that. So staff take the time to get to know the residents and figure out what they like to do best. So these are just some photos that show the differences. So as you can see before, the place felt very clinical, it was very hospital-like, whereas now it's very vibrant. There's engaging things that are on the walls for people to look at. Sometimes it kind of feels like you're walking through a little village with all the decorations and like stuff that you can touch. The walls are very bright, and there's also a lot of natural light. So it's a really warm, just inviting place to be. Before the butterfly model, all the residents, regardless of whatever stage of dementia they were in, they'd kind of be shuffled into a room, and they'd have to eat at a certain time, and you'd see staff going around like, cup of tea, cup of tea, cup of tea. Whereas now each of the lodges have their own kitchen and their own shared dining space, so they can eat more family style, and family members are invited to come in and eat with them as well. And again, just another example of a really warm, cozy kitchen in one of the lodges. So right away, we started noticing some differences after this butterfly model was rolled out in St. Joseph's. So there was a reduction in the use of psychotic medications, and the use of restraints went to 0. And there was a big reduction in the number of falls as well. And I think next I have a little video that just kind of captures the vibe, and there's a short interview with Norma, who's the one who brought all this in. See if it'll work. Oh, brilliant.
Oh, Margaret. I like lots of butter with a bit of turnip. Now, what I want... In Dublin, there's a city where the girls are so pretty. I first set my eyes on sweet Molly Malone.
So Norma, tell us, why is this care home different from others?
I'd worked in acute care before I came here all the time, in general hospitals, and I always felt we failed people with dementia because we didn't understand it. I didn't understand it. I didn't know enough about it. I suppose I started searching what is the best model of care for people with dementia, and implemented what's called the butterfly model of care. One of the aspects of it is that you remove everything clinical. So we've no drug trolleys, we've no nurses' stations, we've no uniforms and no name badges. The whole model is really about finding out who the person is and what matters to them.
Look how young you are there. Look at your handsome husband.
It's really what we're focusing on is what the person can still do, not what they can't do.
So Norma, what would be your hope?
I would like this to be the way people are cared for everywhere. We know this works. The amount of medication people were on was at 78% before we started the model. It's now it went down to 23%. In the first year, falls halved. The restraint went to 0%. What I really would love to see is trainee nurses and trainee care staff, that this is the model that is used to teach people how to care for people with dementia. They deserve it.
Cool. So with that in mind, it was really important for us to understand, okay, we've rolled out this model, but what does it mean for the staff who have to deliver it? And we also wanted to know, what does this mean to the family members of the loved ones who are in St. Joseph's, who some of them have been there for a long time, and they also experienced this transition. So we were really curious about what it was like for them. So to look into this, we conducted a qualitative study design, and we took a very phenomenological approach, and that was informed by a social constructivist paradigm. And what that means is we really just emphasized the lived experiences of the participants. As the researcher, I was very reflective about my own experiences with Alzheimer's and dementia, and we understood that their life experiences would inform their views on St. Joseph's and the model of care. So we recruited staff and family members, and we conducted semi-structured interviews with them. We transcribed them, and then we used thematic analysis to generate themes by following the 6 steps of Braun and Clark. So this came up with 3 themes. The first one was, it only works when everyone is together. So overall, people felt, yeah, this model of care is great, but there were definitely some growing pains in the rollout for both family members as well as staff. So staff just, they spoke about how there always needs to be enough of them on the floor to make sure that they can all have enough time to make the model work as it should. They also had some growing pains. There was a lot of switch ups in role responsibilities because each lodge has their own kind of little set of staff, whereas before it was all the nurses in one group, all the healthcare assistants. So that shake-up was difficult for some people, and as you can imagine, also not wearing uniforms and name tags can be hard because we often, our identity is linked to our work, and our uniform is a part of that. But once the growing pains were overcome, they found that it really does work as long as you don't stop trying to make it work. And some quotes I think that really capture this. So one was with someone from management who said, I think we should be aiming high, don't get me wrong, compared to other nursing homes, it's amazing. So again, we always have to keep trying to make it the best that it can be, but compared to other places, it's phenomenal. Another person said, it's working, it really is working, it's just trying to move people along. So again, change is never easy, but once they got there, it was considered the best way. So that was our second theme, this way is the best way, and people felt that residents could truly be themselves, and they were really respected for who they are and where they are at in their stage of dementia and what they can do rather than what they can't do. And staff really did believe in the model, and all this extra care and TLC from the staff, it also really helped the family members because of course, it's a very difficult decision and process to move your loved one from home to a long-term care facility, but they felt that they could trust everyone in St. Joseph's. They were always welcome to visit. It was such a wonderful place that it kind of brought a sense of relief to them as well, that they wouldn't have to worry so much about their loved ones. So some quotes I really like for this. One participant, her dad had been there for a while, and she was actually also a nursing director elsewhere, and he'd been to a lot of different nursing homes, so she had seen a lot of models of care. And she said to me, when he was in the other facility, I always felt I had to be the nurse, not the daughter, and here I can just be his daughter, so that gift is absolutely priceless. Another family member said that they get the same amount of love and care and compassion in that moment when they need it most. And then our final theme was really about staff. So staff truly do take the time, and this was recognized by the staff, but also the families too. They really put in a lot of work to build genuine and authentic relationships with the residents in St. Joseph's, and as a result, those who live there get such a rich social life in a way that is meaningful to them. And families were greatly impacted by this. They were so moved by how staff would go above and beyond to remember little details and go out of their way to make sure that their loved one was like happy and comfortable. And of course, anyone with dementia, that's what they deserve, you know? So I love this quote. She was talking about how her dad loves musicals. So she said, so I once said, oh, Dad loved musicals and his favorite is West Side Story. And then I came in one week and a carer was like, you'll never guess what, West Side Story is on Netflix now. And she already had it playing, and his knee was tapping with his hand to the music. And she just thought, Jesus, I had said that to her a year ago. So there was so much time in between, but they still remembered who her dad is and what he loves, and she was just really struck by that. Another staff member said, that's what the butterfly is about. It's going the extra mile to find out who the person is and what's important to them. So again, really being in the moment in a feelings-focused way, it really went down well, and staff go above and beyond. So overall, staff and family members of residents felt that the butterfly model was the best way to look after those residents, and care had definitely improved since this radical transition to a very social model approach. Our findings are definitely in line with previous literature on person-centered care, and they're a really great example for other nursing homes, especially those in Ireland, who may want to make a similar change to a more person-centered approach with their own residents. So it's really nice that we can kind of be an example of how this works, the speed bumps, you know, all the difficulties and the best parts of it as well. And I think what's next is we need to dig in a bit more to those barriers and facilitators of this transition if other people want to implement it as well. And I think especially in St. Joseph's, our volunteers are such an important part of the butterfly model. They are absolutely incredible, and you don't really see nearly as much research about volunteers who work in an environment like that, and they really, they are like the sellers of the butterfly model, so it would be brilliant to get their perspectives as well. So that's it for me. On behalf of myself, the staff, the residents, and the family members, thank you so much for being here, and I'm looking forward to any questions that you might have. Thank you.
And we're so lucky to have this super example of good centred care in Ireland. And I suppose one of the important things as well, that the volunteer input has been acknowledged. And I think that's so important as someone who's been volunteering for half my life. And the other thing is, of course, the butterfly model of care, the material citizenship. Again, something that has to be looked at and realised. And we'll come back to, we'll have lots of questions for all of you. So next is Katrina Paluni. I think that's right. And the title, Feasibility of the Tailored Activity Programme for Hospitalized Patients with Behavioural Symptoms Living in a Nursing Home.
Thank you, and thank you to Alzheimer Europe organization to give me the possibility to share with you our research in Italy. I'm Caterina Paolini, I'm an occupational therapist, and I work in primary care in Modena, Italy. And I work at home with people with dementia and their caregiver, and I work also in a nursing home. And I'm here today to share with you our data about the Tailored Activity Program in patients hospitalized with behavioral symptoms that are living in nursing home. First of all, I want to thank my teamwork of primary care in Modena, and in particular Dr. Andrea Fabbo, that gave us the possibility to do this research, and also Barbara Manni, that is the head of the unit where I work. And I would also thank the nursing home Opera Pia Castiglioni, where I work. You can see in the picture the director, Clelia Cavani. So the background is about Taylor Activity Program, that is an evidence-based program for people with dementia and their caregiver to manage behavioral symptoms. And it is an evidence-based OT program, so it changed my practice forever. And you can see the randomized control trial about the effect of this program on dementia-related symptoms. And the aim of this program is to reduce behavioral symptoms or unmet needs. And the focus is on tailored, meaningful activities. So I will emphasize during my presentation many times, it's about evaluating an assessment of the interests and the abilities of the person with dementia. And this program improves quality of life of people with dementia and also their caregivers. It's a flexible program, so you can apply at home, in daily service, in the hospital, and we try to apply also in nursing home. And in Italy is a unique experience because we are 14 occupational therapists that bring the certification thanks to Laura Gitlin, that is the professor of Drexel University that did this research. Let me talk about TAP age, so in hospital, and we try to apply this program in the nursing home. So there are already some evidence about the feasibility of the Taylor Activity Program, and it is a little bit different in the home and in the hospital. In the hospital, the sessions are more, so 11 sessions, and they are briefer, and they are up to 15 to 20 minutes, of course, because of the environment and the organization is different. And the critical part of this program is to identify again the interest and abilities from which to derive a tailored activities, training staff to use activities, and orienting family to the use at this third. So it is divided in 3 phases. The first phase is assessment, the second phase is about training staff using activities, and the third phase is about generalization, the strategy learned through the program. The first part is the most important part of the program. It's about assessment. Assessment of the person, of the caregiver, and of the environment. So the assess of the person is about previous occupation, interest, habits, role, previous role, and abilities. So cognition, functional, psychological symptoms, and so on. And about the caregiver, we evaluate and assess the level of stress of the caregiver and the level of they know about dementia, so also caregiver education is important. And we evaluate the environment about seating, lightings, some rumors, and so on. The second phase is about the treatment, so activity implementation. But as you can see, the first phase of assessment is already an intervention, because when an OT tries to understand the abilities of the person, is already an intervention for the staff. And in particular, in the second phase, there is activity prescription, that is the main core of TAP. So not pharmacological prescription, but activity prescription. And it is an important phase because there is the staff training. And the third phase is about the generalization of the strategies, and the caregiver and the staff learn how to simplify the activities through the dementias going on. So it's not a target. You can use TAP at early stage, moderate stage, to severe stage, and the aim is to modify the activities as the disease is going on. To summarize, the three concepts that we have to take home is that TAP is focus on find the just right activities, thinking about the interest and the abilities of the person. It emphasizes engagement and the things that is new for us as an occupational therapist, that's activity prescription. So in the details, you work with staff to prescribe an activities and try to do them. So our purpose of our teamwork is to compare the effect between the experimental group treated with TAP-H and the control group on behavioral symptoms. Here you can find our sample is of 30 people with dementia who live in nursing home between January 2022 and March 2022. They are living in nursing home in Modena and they have behavioral symptoms. And here you can find the inclusion criteria are about CDR, the stage of dementia, MMSE, the level of cognition, ADL about functional, and neuropsychiatric inventory about behavioral symptoms. And we divided this sample into two groups, so 15 of them received TAP-H treatment and 15 of them received standard O3 treatment. And then we compute the difference between T0 and T1. T1 is after 3 months. And we see the difference of delta MMSE, delta ADL, and delta MPI. And we compare this data using Ampere t-test. Here you can find our results. And there was a clear improvement in the experimental group at the delta MPI assessment. So if we think about neuropsychiatric inventory, the experimental group improved on 31 points at NPI value. And as you see, the control group did not have any evidence of change. And both groups did not change a lot in function and cognition. So, after 3 months, people with dementia who received TAP-H treatment delivered by an OT that has the certification of this program had a greater reduction on behavioral symptoms than people who received a standard occupational therapy treatment. And so we can say that TAP-H is an innovative approach for people with dementia and staff in nursing home, as this pilot study shows. And of course, it deserves further evaluation, and our research must go on and use a larger and more diversified sample. So for conclusion, the TAP-H offers specially designed activities that are customized in individual physical, sensory motor, and cognitive abilities, thus motivating and enabling activities engagement. And tailored activity program in the hospital has a high potential to provide added value to routine in nursing home for people with dementia who have behavioral symptoms and unmet need. Thank you for your attention.
Thank you, Katrina. That was really interesting, and it just again proves the importance of all the various services. And I think probably occupational therapy is one of the most important, and it shows how it has to be person-centered. Our next presentation was from Rachel Daly, and she was from the Centre for Research in Public Health and Community Care from the UK. And unfortunately, Rachel couldn't be with us today. Sharing everyday decisions in care homes. What are the decisions, who makes them, and how? And Rachel's presentation will be available online. I think it's after the conference, all of those are uploaded. So we're now going to take questions from the floor. We'll go to the floor first for the question, and then I can come back to online. So anybody want to start? Somebody at the very back?
Thank you. I think I'd like to ask Mckenzie this. As far as staff attrition, vacancies, sick leave, did that improve as well as their feeling of,
Yeah, so when they made the switch, there was like this kind of awkward moment where a lot of staff left because, again, the shake-up was like, it just maybe didn't suit them, it didn't really fit them to not have their uniforms and that kind of, you know, identity, for example, in nursing. But yeah, St. Joseph's has a really great rate of like keeping their staff afterwards, so I would absolutely say it improved and yeah, way less attrition at the minute. Thank you.
This lady.
Thank you. I have a question for actually Miranda and Mckenzie. Because you told us, Miranda, about the impact of moving in the nursing homes. And I know that in many nursing homes, and Mckenzie, you also told us that, care is organized along stages of the dementia. So people with dementia sometimes make several moves during their stay. So I was wondering, both of you, what's your opinion on that?
Well, in our general study about the impact of relocation within nursing homes, we saw that it's varied between residents, and beforehand we expected mainly negative impact, but we also saw positive impact, especially when a person relocated because of change in healthcare demands. For example, worsening of the dementia. It was positive for the resident to relocate because in a new situation, the staff was really prepared to take care of those forms of dementia. That's what we saw in our study.
I would say for us as well, there were definitely some family members who felt that their loved one really struggled with the shift between lodges and stuff. But yeah, it was kind of a pros and cons where some of them were like, yeah, I'm not sure. They felt a bit distressed at first, but then we found, again, after they were able to settle in, it was a good move for most of them. And one really great thing about St. Joseph's is the layout. Residents can still pop in to like other lodges should they wish. So I think that makes that transition a bit easier. And I think it's a good example of how like design can really help kind of take away some of the other cons that you might find with the transitions between the different lodges. And it's very person-centered. So St. Joseph's is also good about like not just making the decision without talking to the family as well, and having their involvement really helps with that too. Yeah, thank you.
Another question.
Thank you for your presentations. I am Simone de Bruin from the Netherlands, and I have a question to Mckenzie, or actually a remark and a question. Because what you told us about the butterfly model, I find it really impressive. And I see a lot of similarities actually with the model that we have in the Netherlands, which is called the care farming model. I'm not sure whether you are familiar with it. And my question is about the training of professionals, because what we have learned in the Netherlands is that many professionals are very medically trained, and when providing person-centered care and being able to provide care in such an innovative environment, you need different skills. So I'm just wondering, could you say a little bit more about what you think is necessary in training of health and social care professionals?
That's a really good question, and I think the training is so important. So we found that in our study, it was really important for training to regularly be refreshed, but it went beyond just like the model. It had to be a whole culture change. So even in the way they recruit staff now, the interviews are conducted a lot differently to see how people would kind of click with the butterfly model. And then there's also audits, so we regularly are like working on keeping it up to a really high standard, keeping training going, and everyone who comes in goes through like a 2-3 day induction as well. That may seem absolutely crazy at first, with a very enthusiastic activities coordinator. But yeah, so at every kind of stage of staff, like coming into St. Joseph's and then settling into St. Joseph's, training is always being upkept, and it's really about the whole culture change that helps the real medical profession kind of take on that person-centered piece as well. Thank you.
I'm going to take a question from our virtual audience for Helena. We often get questions about the role of sugar in developing dementia. Am I right in saying that there are only risk factors? I'd say these are only risk factors.
Saying that a high blood glucose would be a risk factor. Well, it depends. There is a discussion if it's a high blood sugar or high blood glucose, or if it's a high level of insulin that would be the risk connecting the diseases. And there is evidence for both. And yeah, it's a discussion. But most likely it's a risk factor, at least for vascular dementia.
Okay, Katrina, what kind of differences were there in activities compared to the standard OT treatments?
I think that the changing is use evidence-based program instead OT standard care. And so the difference in activities is about the assessment. The most important phase of this tailored activity program is assessment. And sometimes usual care as OT didn't spend so much time in assessment. And so thanks to this assessment of interest and abilities of the person, you can grade the level of the activity and the complexity of the activities, so to tailor the activity to the person and to his interest. So we can then use this activity prescription that, I don't know if the slide was clear, because activity prescription is for staff that tries to promote the activities and is about how the environment should be, what should I say to the person with dementia, about communication, about what I should ask to the person to get involved in these activities. So it's about details and use something that is evidence-based.
Thank you. So I hope that answers that question. There's lots of questions for the butterfly model, which I'm sure isn't surprising. And I'm delighted to see such a positive response. So I'm going to give a few more before we go back to the floor. So Mckenzie, did these changes to butterfly model require more staff, or can this model be operated with usual staffing levels? And I suppose I'll add this one to it so you can expand. Do you think it's possible for every care home to convert to the butterfly model? I think we all know the answer in the room.
I'm sure all of us believe that it all should be converted to something like the butterfly, but I think it has to be really realistic. So I think you should have realistic expectations. So in St. Joseph's, for example, when the model was rolled out, it was almost happening too fast, and they had to put a pause on it because the families found the change very too quick. So it was really important to kind of slow it down and have a more realistic expectation. And then of course COVID happened, so that had to change staffing as well. I can't remember off the top of my head whether there was an increase in staff. My PI is telling me no. So yeah, the staff stayed the same, and I think what changed the most was the change in the structure to how staff were allocated. Like before, you would have just had your team of like, we're household staff, that's what our responsibility is. We're healthcare assistants, and we're all one team, and we're nurses, and we're all one team. Whereas now they all got completely split up and put into different lodges. And I think that was one of the hardest parts, was just kind of redoing those responsibilities, finding that team again. And that's what made the difference. So if you had the same amount of staff, the challenge came from the switch to that rather than a shortage. I hope that makes sense.
Did you have an increase in volunteers? Did that support the changeover?
Definitely. And all the volunteers, they also go through the butterfly training. They don't come in just kind of expected to buy into it. They get extensive butterfly training as well. So yeah, it's a massive team. And they are the biggest, like, they will wave the flag for butterfly. So it's really nice to have them on board.
Now we go back to the audience. If there's another question.
Thank you. I actually have a question for Helena. My name is Naomi Razing. I'm from the Netherlands, and I have type 1 diabetes, so I'm actually interested from a personal perspective. I'm curious whether you also counted insulin use as or only looked at the oral medications or anti-diabetics. And another question is whether you looked at whether or not the people with diabetes had existing complications.
We have included all kinds of medical treatment, so insulin was quite a large group. And we have no information on any other complications in this register, so that is a weakness.
Thank you. Anybody else? There's another question.
Thank you, Katarina, for your presentation and also for the others. A question for you. If I understood it well, you also implemented this TAP program in primary care. And I was curious about the similarities and differences between nursing home and primary care.
Thank you for the question. It's a good question, and tomorrow I will talk about it. And we collect some data from April 2021 to April 2022 in primary care, so at home. And we, as we said, do two evidence-based programs. So one is COATED, and the other is TAP. If someone doesn't know, COATED is Community Occupational Therapy in Dementia, and it focuses on quality of life for people with dementia and their caregiver. And the Taylor Activity Program was born to apply it at home. So the main focus is home with people with behavioral symptoms. And so I think that the difference is that at home you train the caregiver, who is a familiar or something else of the family, to do the activities and to understand the power of activities in manage behavioral symptoms, and the caregiver learns also to graduate the activities to the stage of dementia and to their abilities. And I think that one of the family is more motivated sometimes than staff training that works in nursing home, because no, everybody have the chance you you explain us about, and training staff sometimes it's challenging, but it's so important.
I just want to pose another question to Miranda. This one is, in our country, the relocation of people with dementia is often triggered by behavioural problems. What is a good approach?
Well, I'm afraid I can't answer that question because it was a first study we did to get a broad overview, so I haven't get information and insights on that part.
So, any other questions in the audience? This lady.
Yeah. I just wondered, a few of you have touched on the issue, or volunteers, and I think some of your studies were actually undertaken during COVID when, I understand, well, in Australia, volunteers weren't actually allowed into residential aged care anyway. I just wondered whether, we're not quite through COVID yet, but are they coming back? So and what actually do they do in some of the programs that you were talking about today?
Yeah, so COVID greatly impacted the volunteer program in St. Joseph's, like in a really big way. Slowly coming back, and pre-COVID they're kind of like little butterflies themselves. They fly around, and they're the ones who really can kind of sit down with a resident, have a cup of tea with them, really have a chat with them. They support the staff just for, you know, engagement, doing meaningful activities. And during COVID, it was very difficult because the volunteers had to get involved in other ways. You know, they might have done more things around like fundraising and that type of stuff rather than being in the lodges, because they were not allowed in there if family members couldn't be allowed in there. But yeah, so COVID did have a great impact, and now that they're slowly like coming back, they'll be able to get into the lodges, play games, do more activities, and just support the staff as well. Anyone else?
Thank you, Mckenzie. Anybody else? There's a lady over here.
Hi, thank you for wonderful presentations. I'm Lilia from Iceland, and I'm curious how many people live in each lodge in the, yeah.
I think it's like, is it 6 to 8, is it? Yeah, I think about 6 to 8. Yeah, so they're very small, and it's like they have rooms, and then they have their shared space, so it really kind of feels like you're going into like a family member's house. By no means does it feel crowded. Yeah, and it's a really good staff ratio as well, so only 6 to 8, up to 10 sometimes.
I'm just going to ask the girls if they have anything they want to add themselves. Have you any other comments? No? Everyone's happy? Anybody else in the audience? We're all happy. It's been an absolute privilege and a pleasure to have been involved in this session, to chair it, and I want to thank you all for attending it. Also, I suppose we have to take this opportunity to thank Alzheimer Europe for providing this opportunity for us to all mix and network. It's amazing, and we're only started. We have 2 days, really. So for me, it's been a privilege to come over. I was a former carer for my mom, and I've worked building dementia awareness in Ireland. And I have to say, in 2017, this magnificent lady at home, Helen Rochford-Brennan, which some of you will know lives with early onset Alzheimer's, and she would be here except she had a health setback. So, and we've finished now her term in Alzheimer Europe. The working group is over. But I have learned so much during that time, and our new chair, Rosario, of the board is here. So hopefully we'll get to work and meet again, but it's been a privilege. Thank you. And I think lunch is next. Thanks a lot.